So good evening, everyone. So welcome all to this evening here in India and morning across in Canada. So we have a very interesting evening this today. So we have a session on high flow nasal oxygen, and we have with us two esteemed speakers. So we all have heard of Professor Laurent Brochard. So Professor Laurent Brochard is Professor of Medicine, and he's an Interdepartmental Division Director of Critical Care Medicine at University of Toronto, Canada. He holds the Keenan Chair in Critical Care and Respiratory Failure, Department of Critical Care at St. Michael's Hospital. He's editor-in-chief in Intensive Care Medicine and a deputy editor of American Journal of Respiratory and Critical Care Medicine. So done a lot of work in respiratory area. And he has mentored over 18 PhDs and many leaders in critical care. So he has published over 520 peer-reviewed publications. We've had an opportunity to publish our Delphi consensus recently with Professor Laurent Brochard as well. So I welcome Professor Laurent Brochard. He would be presenting on role of HFNO as respiratory support in adults. Following which there'll be a talk by Mr. Thomas Pirano. So Mr. Thomas Pirano is a clinical educator and respiratory therapy services at St. Michael's Hospital, Toronto, Canada. He works with Professor Laurent Brochard, and he has delivered lectures at various places and an astute researcher and an astute teacher. And his areas of interest is mechanical ventilation, HFNO, and monitoring in critical care environment. And he's also on the editorial board of Respiratory Care Journal and the Canadian Journal of Respiratory Therapy. So I welcome both Professor Laurent Brochard and Thomas Pirano for this enlightening evening. So without wasting much time, we'll go on to the talk from Professor Laurent Brochard on the role of HFNO as respiratory strategy in adults. So we'll have both talks. After this, Mr. Thomas Pirano will be talking on practical implementation of HFNO. After which we would summarize the talks, and then we would have a session with questions and answers. Thank you, Professor Laurent Brochard. Do you have anything to say? Then we can go on with your talk, Professor Brochard.
No, thank you very much. I'm really glad to have this session on such an important and active current topic. Thank you.
Thank you. Thank you. Pirano, you have anything to say?
No, thank you for the opportunity to speak. And yes, a very exciting topic for us to be presenting. Thank you.
Yeah. Thank you, gentlemen. We can start the sessions.
Thank you very much for the invitation. My name is Laurent Brochard. I'm intensivist in Toronto, Canada. And I'm very pleased to present on the role of high flow nasal cannula as a respiratory support strategy in adult patients. So my laboratory has been working with a number of companies which are listed here, including Fisher-Paykel for equipment. I'm also leading the international group called the Plug, which has recently initiated the guidelines for high flow nasal cannula. So non-invasive support can be needed in different situations, different conditions, different type of disease. COPD exacerbation or hypercapnic respiratory failure in general, as you know, is a very good indication for non-invasive ventilation with 2 levels of pressure, and we'll discuss that a bit later. Cardiogenic pulmonary edema has been also very good indication for non-invasive ventilation and CPAP. And post-operative respiratory failure until now has been treated frequently with either non-invasive ventilation or CPAP. Where we had the most difficulties was really hypoxemic respiratory failure, like patients with pneumonia or ARDS, and it's a very large group. And in this group, when you look at, you compare the effect of non-invasive ventilation, the classical bi-level technique, and you compare to chronic patients like COPD exacerbation, this graph was a multi-center observational study, which indicated that if you do multivariate analysis, the fact that patients are successfully treated with an IV, well, significantly reduce the risk of death, whether the patients are acute, the black dots, or chronic patients. However, if the patient fail an IV, the situation is very different with acute and chronic patients. Chronic patients, you do not impact the outcome. By contrast, in acute patients, so like pneumonia or ARDS, the patients who fail an IV, this is a significant risk factor for mortality. So you may improve some patients by when you're successful, but you may worsen some patients. And the window for delivering NIV in hypoxemic respiratory failure may be very short in terms of severity and time. If you deliver too early, it's either useless or even uncomfortable. If you deliver too late, it may be risky or dangerous. And when you look at the lung-safe study, which look at patients with ARDS, it was interesting to see that NIV was used whatever the severity of the patients. But the risk of failure of NIV, and of course it was selected patients, it was not all ARDS patients. When you look at the failure rate in the moderate and severe, it's close to 50%. So if you remember that those who succeed may benefit from NIV, but those who fail may worsen with NIV, well, it does not seem that we have a very good technique in this indication. And this is where high flow really started to be interesting in this type of patients. And high flow is a very interesting technique made of different components which explain the different mechanism. So as you know, it's a flow and FiO2 controller, which means you deliver a relatively high flow, and high flow means it's higher than the patient's own peak flow. That's why we are often in the range of 45, 50, 60 liters per minute, because it's rare to have patients having a peak inspiratory flow much higher than that. Then the gas is humidified and heated, so you deliver a very physiologic gas in the patient's airway, which helps to make it very comfortable. It's delivered through non-condensing tubing, which avoid condensation in the tubing and for instance, flooding the patient's airway. And it's delivered through nasal cannula, which is a very simple approach, which makes the patient still able to open his mouth, to speak, and make it more comfortable. So the four main mechanisms, I would say, for the benefits of high flow are that you can match the patient inspiratory flow, so you have a stable FiO2. It delivers some positive pressure in the nasopharynx, so at the entry of the respiratory system. So it's a CPAP effect. It gives a very good humidification and comfort compared to the other non-invasive techniques. And it has this very attractive feature that it may wash out the nasopharyngeal dead space. So the gas you expire is completely renewed by the fresh gas. And this may explain, this is a nice physiological study, that when you look at the effect in patients with acute respiratory failure, well, you see an improvement in oxygenation. Again, always a little bit difficult to interpret because you're not sure you compare to the same FiO2, but it seems to be consistent. But when you look at an estimate of the minute ventilation, so how much ventilation the patients are taking, it's significantly decreased in most patients. And this explains that the work of breathing, or the pressure time product here, goes down. So this is very interesting, because you decrease the need for minute ventilation by decreasing the dead space. And this is a kind of internal assistance for the patients, different from the external assistance when we give positive pressure with bi-level ventilation, for instance. So this washout of the dead space is an important effect, and of course it depends on how much flow. It depends also probably a little bit whether the mouth is open or closed, but it may still exist even if the mouth is open. The positive pressure effect may be slightly less if the patient opened the mouth. So there are many possible combination of the effect. This was a nice editorial by Ewan Gallagher and Art Slutsky, describing the different possible mechanism which may explain the clinical benefits, and you see all going to potentially improve clinical outcomes. So because we have seen a number of studies in this field, we found it was time to have a clinical practice guideline using recommended procedure. And this was done completely independently from industry and published in Intensive Care Medicine, following 4 publications with different systematic review and meta-analysis. And these guidelines addressed 4 main questions. The first one was hypoxemic respiratory failure. So what's the place of high flow nasal cannula? Should it be used in this clinical setting? The second one was use of high flow following extubation. The third one was the post-operative patients, especially high-risk patients or obese patients following cardiac or thoracic surgery. And the fourth question was, is it useful in the peri-intubation period before intubation? So if we look at hypoxemic respiratory failure, and as I mentioned, this is where we really needed the technique to help us or to help our patients. You can see, despite the moderate certainty, it's a strong recommendation to use it in hypoxemic respiratory failure. And there is no question that the results of the systematic review and the different studies are very, very highly influenced by this study, which was the Florali study. That was a randomized multi-center trial performed in France by the RIVA network. And there were 3 groups of patients, mostly patients with community-acquired pneumonia, and a large percentage of patients with bilateral infiltrates, which could probably be diagnosed as having ARDS. And when the result was looked in the group of patients who were below 200 millimeters of mercury of PF ratio, there was a very significant reduction in the rate of intubation in the group using high flow. So you see NIV, standard oxygen, and by the way, there is no difference between NIV and standard oxygen, so no benefit of NIV, but a very strong reduction in intubation with high flow. This was not significant when you use the whole group, so even patients with PF ratio below 200 and 300. And one could say, well, in strictly speaking, it was a negative study. But what was important was that even if you look at the whole group, so all patients together, when the rate of survival was compared between the 3 groups, it was significantly better in the high flow. So even if the intubation rate was not completely significant in the whole group, the survival rate was better. And again, you see no benefit of using NIV in this group. So these results have not been consistently found in all the studies, but overall, the effect, it's a graph down here. The effect on the intubation rate, so the need for invasive mechanical ventilation, is significantly reduced by using high flow nasal cannula. There is no demonstration in this meta-analysis of an effect on mortality, but this result supported for the group the recommendation of strong recommendation in patients with hypoxemic respiratory failure. As you probably know, this has been used a lot in patients with COVID-19. This was not included in the systematic review. And the data so far suggests the same. This is there has been no randomized trial, sorry, but this is a nice study because they try to match patients receiving high flow versus those receiving only oxygen. And they were able to show a significant reduction in the need for invasive mechanical ventilation, even if there was no difference in the ICU mortality, which, however, is still a good result because you spare the need for mechanical ventilation in a number of patients, even with COVID-19. So this is the first strong indication. The second question was whether it could be used following extubation, of course, to prevent reintubation. And as you can see, it's also a recommendation, but it's a conditional recommendation. So clearly less strong than for hypoxemic respiratory failure. And the reason is that the literature is a bit more diverse in this indication. So there's been a couple of studies by the group of Hernandez published in JAMA, and this one is showing that even in patients at relatively low risk for reintubation, so no specific risk factor, high flow therapy significantly reduced reintubation from 10 or 12% to 5%. These results have not been reproduced by all groups. This is a different approach. This is a comparison with non-invasive ventilation, so BiPAP in patients after cardiothoracic surgery. And the reason it was compared to non-invasive ventilation is because there are strong data suggesting, especially after thoracic surgery, that BiPAP may be useful to prevent reintubation. And as you can see, there was no difference between BiPAP and high flow oxygen. So you could say, well, if it's not different, high flow is easier to administer and more better tolerated. So we should probably use high flow. But you also have data like this one. This is a group of Arnaud Thiel in France, who selected patients who were at high risk of extubation failure, defined by age greater than 65 and or an underlying chronic cardiac or lung disease. So group of patients for whom we know that the risk of reintubation is maybe 15% or more. And in this group, they show that this is the rate of reintubation, that the use of non-invasive ventilation combined with high flow, so the alternating sequences of high flow and NIV, was the best approach for the patients, with a reduction from like 18% to 12%. So the results are not always consistent. You see the effect of reintubation is significant compared to standard oxygen, but compared to NIV, the data do not show major difference, so there is no clear benefit compared to NIV. And as you have seen, at least one study showed a better effect of NIV. So overall, the high flow seems to be preventing reintubation, but maybe we need to know a little bit better which patients should be targeted. There is no significant demonstrated effect on mortality. The third question addressed by the guideline was the post-operative period, especially following cardiac or thoracic surgery, and especially looking at the patient with high risk for failure or need for reintubation or obese patients. So again, this was preceded by a publication with a systematic review and meta-analysis published in Chest. And you see that in patients defined as being at high risk because of comorbidity, because of obesity, there was a very significant reduction in the risk of reintubation by using high flow. In patients with average or low risk, there was no effect. So in total, reintubation seems to be prevented by using high flow, but especially in high-risk patients. If you look at the escalation of therapy from oxygen to high flow to NIV, it was significant in the group with average risk. So you could say, well, it prevents the need for having more invasive therapy, even if it does not prevent the reintubation in that group. And again, no difference in mortality. This is when looking at different types of surgery. So you see this is cardiac surgery, thoracic or abdominal surgery. You don't have many studies, so it's difficult to be very strong, but it seems the trend is the same in all surgery. There is a small benefit in terms of hospital length of stay, which makes sense, right? If you don't reintubate as many patients in that group. The last question was the peri-intubation period. Is it useful to pre-oxygenate patients before intubation with high flow therapy? And that's interesting because the results are very different in the ICU compared to the few studies which look at that in the operating room. And in the ICU, this is the bottom of the slide. The studies have been unable to show benefit of this technique as a pre-oxygenation technique, which is different in the operating room. So the conclusion was that the use of high flow does not decrease hypoxia and does not improve the intubation process compared to conventional oxygen therapy in the peri-intubation period. And the result, again, contrasts with the operating room. So we don't know exactly why. Maybe it's patients with less reserve, but there is no need to use this technique systematically based on this data. So the guidelines discuss other indications for which there is really limited evidence. There is conflicting and limited evidence supporting high flow during bronchoscopy or during transesophageal echocardiography and endoscopy. For the acute respiratory failure in the emergency departments, there have been conflicting findings and on respiratory support and the need to escalate support. And there is the possible physiological benefits in patients with hypercapnic respiratory failure and congestive heart failure, but we have no demonstration of an impact on outcome. And I'd like to show you a few additional data on that. So this is a nice study by John Fraser in Australia and his group, showing that in stable COPD patients, they could show a decrease in respiratory rate. So be careful with the scale. It looks very large, but it's not such a big decrease, but it was significant, and a slight decrease again in transcutaneous CO2. Interestingly, they also found that there was a signal indicating that this may also increase N-expiratory lung volume, which is something which we would not like in COPD, so we don't want to increase distension. We have looked at this technique in patients with cystic fibrosis, which is not COPD, but it has some similar characteristics, like a high level of PCO2. And it was interesting because compared to NIV, for instance, it decreased the respiratory rate a bit more, and it allowed the patient to take a slightly larger tidal volume. So there was an interesting effect on physiology with a better ventilation, and the recommendation from this data suggests that maybe alternating the NIV and the high flow may be interesting in this population. But we don't have really strong data in exacerbation of COPD. That's why this data by Nutapol Ritayamai, who has been a fellow with us in Toronto and who looked at these patients in Bangkok, in Thailand, when he went back. These data are really interesting because so it's not randomized. They just had patients who were treated with non-invasive ventilation. As I told you, this remained the reference technique for exacerbation of COPD. Patients had improved, so they were not in the very acute phase. And they looked at the effect of high flow, comparing 10 liters per minute, 20 liters per minute, 30, 40, and 50 liters per minute. And they found that when increasing the flow up to 30 liters per minute, they could decrease the esophageal pressure time product, which is an index of the work of breathing, of the effort of the patients, approximately to the same level of NIV. But when they increase the flow up to 40 or 50, at least in some patients, the work of breathing seems to increase. Why? We don't know exactly, but it's possible that patient did not tolerate such high flow. Maybe because their own peak flow is not that high, or maybe also because when delivering very high flow, you may increase the resistance to breathing, and these patients who already have high resistance may not tolerate very well. So interesting result, but if you apply this technique in patients with high airway resistance, either asthma or COPD, be careful, because it may be slightly less tolerated. And it's possible that in this group of patients, we may need to have an individual titration of the flow. So we don't have enough data for sure to make recommendation. So the summary of the guideline again is that there is a strong recommendation for hypoxemic respiratory failure, conditional recommendation for post-extubation to prevent reintubation, probably need to select the patients. Conditional recommendation for post-operative patients with hypoxemia, for instance, and interesting in high risk or obese patients following cardiac or thoracic surgery, and no recommendation for the peri-intubation period. So high flow systems may provide optimal humidification to the airway, which may be important for secretion and comfort. By reducing dead space, high flow nasal cannula works like an internal assistance. It may depend a bit on the mouth opening, and this very well tolerated system may become the first line therapy in hypoxemic respiratory failure. with post-extubation and post-operative period as possible indication. But its use in association with other techniques may also be interesting. And I've showed you a couple of studies where they combine NIV and high flow oxygen therapy. Thank you very much for your attention. I'd be happy to answer your questions, and you can also visit our blog, coemv.ca, where we discuss a lot of interesting or exciting issue about mechanical ventilation. Thank you very much.
Thank you very much, Professor Brochard, for that excellent overview on the indications for HFNO and the recommended recommendations from the article that is published. So we'll go on to the next talk by Mr. Thomas Pirano, and after that we would possibly take the questions. So over to Mr. Pirano.
Thank you so much for the opportunity to discuss the practical implementation of nasal high flow therapy. I have some disclosures to make. I have received payment for speaking in the past 2 years from Drager, Fisher & Paykel, and Phillips. I'm going to discuss the initiation of nasal high flow therapy. We've had a discussion on the recent guidelines. Now I'm going to discuss practical areas in terms of how we initiate it, who we should initiate it on, when we should initiate it, but both related to the acute management, which would technically be avoidance of intubation or avoidance of escalation of care, so trying to avoid patients from needing more advanced therapies like non-invasive ventilation or invasive ventilation. And then I'm going to discuss the post-extubation, sort of the recovery phase of patients, and I'll leave that for the end of the presentation. I'm going to discuss monitoring of patients, so how to effectively assess how well high flow nasal cannula or nasal high flow therapy is working on a patient. And then I'm going to discuss some recent data, and this is related to post-extubation, where combining therapies may be more beneficial in terms of using nasal high flow with non-invasive ventilation. And then I will discuss amongst this concerns with delaying intubation. I just have some points to make regarding making sure that we're not delaying intubation in patients, and this will really come full circle into the monitoring. So this will be part of the monitoring section as well. So let's first discuss the initiation of nasal high flow therapy. There are probably many different criteria for initiating high flow therapy, nasal high flow therapy. They would be different between organizations, between hospitals. This is just an example of combined criteria that have been used in research studies. So this is an example that if you cannot maintain a patient's oxygen saturation between 90 and 94% while receiving a face mask that is delivering at least 10 liters per minute or more of flow, or if they're on a Venturi device or some mask device that can give a precise amount of oxygen, if they are on 50% or more, and this is what's needed to maintain the saturation of higher than 90 to 94. If the patient's breathing at 25 breaths per minute or more, if you see signs of increased work of breathing, or if they are, and they must be hemodynamically stable. So a patient who meets any of these criteria but are not hemodynamically stable, they may require more urgent intervention in terms of invasive ventilation. But assuming they are hemodynamically stable, this is the typical criteria of when we should consider initiating high flow therapy in patients, or nasal high flow therapy. So in terms of settings, typically many will say you can start at 30, you could start at 40. I use this example because typically most patients will tolerate 40 and 50 liters per minute of flow. So starting at 40 and then increasing it as patients tolerate it to a minimum of 50 liters per minute is likely ideal for many patients. Around 50 liters per minute is the average flow used in many studies after they report. So most will start lower, but then they report the final value, and 50 is typically around the average that's used in most studies. And then you could increase it to 60 liters per minute if there is patient demand or a high respiratory rate that does not seem to be resolved with 40 or 50 liters per minute. So I would quickly try to get them from 40 up to 50. And then if they are still working, they still have a high demand, I would increase that flow to 60 liters per minute. And then if a patient complains of nasal discomfort, you can decrease the flow, but try to maintain a flow of 40 liters per minute or higher, especially in the acute phase. But keep in mind that the size of the cannula may impact the nasal discomfort. So I have a slide here from a paper that was published in Critical Care in 2020, and it was a bench study, but it represents that the size of the nair, the diameter of the nostril, if you have a smaller diameter and you're using a larger tube, or a larger cannula size, I should say, you can see that the pressure generated in the nasal pharynx can be quite high. This is up to 12 centimeters of water. And of course, these are different flow rates. So once you get to 60, you can generate a reasonable amount of pressure when there's not much space around the cannula. Of course, if you have a smaller cannula size in the same size nostril, you can see the generated pressure is much lower. Now, some of this pressure it may be beneficial to be generated, but really the tolerance of the therapy is key. So if you may be generating high pressures, but if the patient does not like it and doesn't tolerate the therapy and begins taking the cannula out of the nose, you need to compromise. So you either need to change the flow rate, which the flow may be helping with other things such as CO2 washout, anatomical dead space washout with the high flows. So you may want to keep the flow, but you may need to change the size cannula that you're using with this patient if they complain that it's too much. You can try lowering the flow, but consider taking a look at the cannula and see if it's maybe taking up too much of the nair. And then finally, starting at a temperature of 37 degrees Celsius is what's recommended, but please note that some patients may find this uncomfortable. There has been a study showing that there's two temperature ranges that were used here, 31 and 37. Patients on average found that 37, there was a lower comfort score, so higher comfort score means there's more comfort. When they looked at patients that were on 31 degrees of temperature, and they found patients were also uncomfortable at higher flows, at flows of 60, if they were on lower amounts of O2. So these are patients that are probably not as severe. They probably don't have as fast of a respiratory rate, as much of a drive, and giving them a lot of flow in their nares, it may not be comfortable because they really just don't have the demand. Whereas patients requiring more FiO2, they didn't have a problem with the higher flows, but they did have a problem with the higher temperatures. Now, this was 40 patients. This is not generalize all patients that ever get high flow nasal cannula. So start with the initial recommended setting of 37 degrees Celsius, but don't feel like you're doing something wrong if they complain of the heat. If they say it's too hot, try a different setting. Again, tolerance of therapy is key. 31 is not as optimal as 37 for these patients, but it is something, and it will provide that comfort that will allow them to keep the nasal cannula on. So this is just an important aspect. And if you're using a device that has a medium temperature, then you could use something in between. For example, the Airvo line of devices, I do know that they have a 34 degrees option, so you could meet somewhere in between there. And just to give you an example of this, the best comfort settings, these are pretty equal, and this was high flow at 30, high flow at 60, at 31 degrees. They were the more comfortable settings in this study. And probably the worst combination of settings that they found was 30 liters per minute of flow at 37 degrees. So low flow, high temperature seem to be the least tolerated in terms of comfort. Now, let's talk about acute management. So these are the patients that present with hypoxemic failure or respiratory failure, and I'll discuss both types of respiratory failure, hypoxic, and I'll have a couple of things to say about hypercarbic failure. And these are patients that present, they have acute respiratory failure, and before you decide which therapy to use, you have to consider what is still considered the gold standard. So I would say generally always consider non-invasive ventilation as a first-line therapy if the patient has hypercapnic failure secondary to a chronic lung disease. So acute on chronic COPD exacerbations, you would want to deliver non-invasive ventilation. It is where we have the best data, and it is the gold standard. Cardiogenic pulmonary edema, you will likely achieve better pressures to help with the edema and atelectasis by using non-invasive ventilation. And any development of hypoxemia post-abdominal surgery. So there has been studies looking at high flow nasal cannula compared to non-invasive ventilation in post-op abdominal surgery patients. And again, likely due to the nature of surgery, there may be atelectasis that really requires that dedicated pressure, that sealed interface. And therefore, these are the types of patients that probably you should still use non-invasive ventilation as a first-line therapy. Where you would consider nasal high flow as a first-line therapy is if the patient has de novo respiratory failure. So for those who aren't familiar with the term de novo respiratory failure, a definition would be hypoxemic respiratory failure in the absence of underlying chronic lung disease or cardiac failure. So keeping in mind that patients with COPD or cardiogenic pulmonary edema, they will present with some elements of hypoxemia. So just to say, give non-invasive, to give to everyone nasal high flow who presents with hypoxemia, you have to consider the underlying cause. So when these underlying conditions do not exist, this would fall into the category of de novo respiratory failure. And an example would be community-acquired pneumonia in someone who doesn't have cardiogenic pulmonary edema or COPD. So the average person coming in with community-acquired pneumonia, they would fall under this category. And immunosuppressed patients, although there is current guideline recommendations that non-invasive ventilation could be used in immunosuppressed patients, there's more and more data suggesting that the least invasive you can be with these patients, the better, provided they respond to therapy. So nasal high flow therapy may perform or outperform non-invasive ventilation in these patients. So I would consider nasal high flow as a first-line therapy for these patients as well. Now, just to give you an example of community-acquired pneumonia, I mentioned that de novo would be patients without COPD. This would be an example of patients without COPD. And when you look at patients with COPD, when given non-invasive ventilation, this is a small study, but it demonstrates this quite nicely, that if the patients have COPD and pneumonia, giving non-invasive ventilation as a first-line therapy avoided intubation in these patients. So significant difference in avoiding intubation. All 12 patients here avoided intubation. They received non-invasive ventilation. Standard treatment, which was just oxygen therapy, not nasal high flow, mind you, but this is just standard oxygen therapy. They did not avoid intubation. Patients without COPD, non-invasive ventilation or standard oxygen therapy, there is no difference in the avoidance of intubation. Therefore, non-invasive ventilation does not help patients who, again, in this example, they did not help avoid intubation in this study. So it's important to note that if someone comes in with pneumonia, but also has COPD, you would still use non-invasive ventilation as a first-line therapy. If they do not have this underlying disease, then you would likely want to start with nasal high flow therapy. Now, if you are treating with non-invasive ventilation, you have to understand some of the limitations. And if you look at the risk factors of failing non-invasive ventilation, you'll see community-acquired pneumonia is right there, acute respiratory distress syndrome is there, and immunosuppression is there. These are all risk factors, as is a hypoxemia with a PF ratio less than 150. So again, knowing that there's risk factors, and when patients fail, this is a risk factor for failing non-invasive, and non-invasive failure is a risk factor for mortality. So be sure you understand who you're applying non-invasive ventilation to and when it may be more ideal to initiate nasal high flow therapy instead. So high flow nasal cannula compared with conventional oxygen therapy for acute hypoxemic respiratory failure. This was a systematic review and meta-analysis that was published just prior to the guidelines that were discussed. And this found that overall, there was one study that got everyone very excited, showing a reduction in mortality in patients treated with high flow nasal cannula or nasal high flow therapy compared to standard oxygen therapy and non-invasive ventilation. However, when all studies are combined that currently look at this as an outcome, they found that overall, if you're not familiar with forest plots, anything that crosses this 1 means that it was there's no significant difference between high flow nasal cannula or standard O2. You want this black diamond to be sitting on one side or the other. If it crosses, there's no significant difference. So mortality, we still don't have enough data to suggest that nasal high flow therapy will reduce mortality in patients. However, we do have data suggesting that you can avoid escalation of therapy, pardon me. So this is avoidance of non-invasive ventilation would be an example, or avoidance of intubation, which is the next slide. And you can see overall the black diamond is in favor of high flow nasal cannula for avoiding the escalation of therapy, and the need for invasive ventilation also favoring high flow therapy, nasal high flow therapy. So this was the systematic review that really pushed the guidelines forward. I would say many of these studies obviously did, but the guidelines, the reason why they recommend high flow therapy or nasal high flow therapy for patients with hypoxemic respiratory failure is because of this ability to avoid escalation of care and the need for invasive mechanical ventilation. This paper did find that there was a 4.4% absolute reduction in the need for intubation, the number needed to treat 23, which is not a very low number. Ideally, you would want this number needed to treat much lower, but you have to consider that. So if you treat 23 patients, at least 1 will avoid intubation. But in some therapies, 23 may not be good. For example, if you were giving a drug that after 23 patients that received the drug, 1 person would avoid poor outcome. But there were side effects to the drug that caused other problems, then a number needed to treat of 23 would not be ideal because there would be harm in the therapy or other issues created with the therapy. Nasal high flow therapy is not one of those things. There is no evidence that nasal high flow therapy will cause any harm or any other concern. So because it's a safe and effective therapy, it makes sense to use it in the context of hypoxemic respiratory failure over using something like conventional oxygen therapy. So there you have it. Now, in terms of hypercarbia, the jury is still out in terms of, what are the boundaries for using high flow nasal cannula or nasal high flow therapy in patients who are hypercarbic. And this is an interesting paper published in the Annals of Intensive Care Medicine in 2019 that looked at worker breathing compared to non-invasive ventilation and then different flow rates of high flow nasal cannula. And please forgive me if I switch between nasal high flow therapy and high flow nasal cannula. I'm referring to the same therapy, and I'm sure you're aware of that. Many of the papers will call it high flow nasal cannula. So they compared non-invasive ventilation, and when switched to high flow nasal cannula, you can see compared to non-invasive ventilation, if you want to look here, this is probably the easier one to look at. It's the pressure time product per minute. You can see that it increases compared to non-invasive ventilation. High flow nasal cannula at 20 liters per minute, it's still elevated. High flow nasal cannula at 30, you can see it's now fallen back into the same area as non-invasive ventilation. And then we have high flow nasal cannula at 40. You can see it's quite similar, but 50, it's now increasing again. And I would suspect that 60 may have actually increased even higher. The point of this slide is that with COPD patients, or with hypercarbic patients, I should say, we may find out that the level of flow is extremely important for COPD patients. And I think we still need more data to not only determine which is the ideal patient who's in hypercarbic failure, where they would benefit from high flow therapy, nasal high flow therapy, and perhaps what flow rate is ideal. And of course, it won't be the same for every patient, but on average here, the number of 30s seem to be better than the other flow rates. So just to keep in mind that flow is likely important. There is one systematic review and meta-analysis that I was able to find when I looked this subject up in 2020. The issue with this systematic review, so what it showed is that high flow nasal cannula compared to non-invasive ventilation, it appears that there's no difference in the management of hypercarbia. So one might take this information and assume that this means that you could treat hypercarbic respiratory failure with high flow nasal cannula or non-invasive ventilation and have the same outcome. However, there were 5 randomized controlled trials included, and 3 of them were extubated patients. So you have to understand that patients who are hypercarbic after they've been treated medically, so they're not actively in failure, they're actually in the recovery phase, but still hypercarbic, are very different than the patients who present to an emergency room or the intensive care unit who are in acute failure with hypercarbia. Obviously very different patients. So the fact that 3 out of the 5 randomized control trials included extubated patients, it doesn't really answer this question at all, whether or not high flow nasal cannula is similar to non-invasive ventilation for the management of hypercapnic respiratory failure. Good news is we have upcoming studies. This is just an example of 2 protocols that have been published online for studies that are planned and or ongoing currently. One is the comparison of high flow nasal cannula and conventional oxygen therapy for support during acute on chronic respiratory failure. This is a multi-center randomized controlled trial. And then this is a high flow nasal therapy versus non-invasive ventilation in COPD patients with mild to moderate hypercapnic acute respiratory failure. And this, again, these are just publications of a study protocol, and this study would be a non-inferiority randomized control trial. Non-inferiority randomized control trials are typically what's used when something is already established as a gold standard. And because non-invasive ventilation is a gold standard in this clinical context, then you would need to do a non-inferiority trial to see whether or not high flow therapy is as good or non-inferior to non-invasive ventilation. So this is the study I'm probably most excited to see the results of. I think this one really would be specific to answer the question which I brought up in the last systematic review. So to summarize the acute management, and as I go along, I'm going to provide a summary on each section. That way I don't have a long-winded summary at the end. But to summarize acute management, non-invasive should still be used. So this is non-invasive ventilation in the form of BiPAP. So 2 pressures should still be considered the first-line therapy for certain patient populations, and that goes without without argument right now. We should consider high flow therapy when oxygenation cannot be sustained with less than 10 liters per minute of oxygen flow direct, or with providing 40% oxygen or less. So once they're on 50% or needing 10 liters per minute or more, we should consider moving forward, and or when work of breathing appears elevated, and of course respiratory rate is elevated. Most guidelines will use a respiratory rate of 25 to 30 as a threshold for starting high flow therapy. Nasal high flow therapy may avoid escalation of therapy and the need for invasive ventilation. We have data to support this, and this is why the guidelines recommend this. And more data is required for suggesting treatment of acute hypercarbic respiratory failure. There are many studies ongoing looking at this, and we still need more data before we can make a conclusive argument. For now, non-invasive ventilation for hypercarbic failure is still first-line therapy. So monitoring of high flow therapy, this is important in terms of how do you know your therapy is being effective? And why this is important is because there is always a concern with non-invasive ventilation that you are delaying intubation. And there's evidence that delaying intubation in a patient leads to poor outcomes. So currently, there are not many studies in the potential delay in intubation related to delivering high flow nasal cannula. There is this paper in Intensive Care Medicine published in 2015 that basically showed that patients who are intubated earlier, so this is early high flow nasal cannula failure compared to late high flow nasal cannula failure, the overall ICU mortality, extubation success, ventilator weaning, and ventilator-free days are all significantly better in patients that fail earlier rather than those that fail late. Now, the issue with studies like this is that late failure could be a progression of a condition. It doesn't exactly mean that the patients were failing earlier, and that's what's important to understand. So I'm going to talk next about a score that's been used, that has been used clinically, and I'll bring up some of the papers that have used this score. But the purpose of the score is to see if the score would have predicted failure of high flow nasal cannula. And if it does predict failure of high flow nasal cannula, perhaps early intervention will avoid poor outcomes. And this is the whole concept behind what this paper published, which is the ROX index. So the ROX index looks at saturation divided by FiO2 divided by respiratory rate. So the beauty of this score, the simplicity of it, is really what makes it a nice tool. And I'll talk about some of the limitations of the values that are used and how we can work around this. But really, it's things that are readily available. If you have a saturation monitor, you know what FiO2 your patient is on, and you know the respiratory rate, you can calculate the ROX index. You don't need any blood work. You don't need an arterial blood gas or a venous blood gas. You have everything you need. Now, in this paper, I want to make it very clear that this paper did not use the ROX index to determine whether or not they were going to intubate a patient. The purpose of developing this score is to see if you could predict failure in a patient, and if you can predict that they're going to fail, then perhaps you should intervene earlier. That was not the purpose of this paper. This study literally was a study of high flow nasal cannula. They had patients that met criteria for high flow nasal cannula. All of them, the respiratory cause of failure had to be pneumonia for inclusion to the study. And this is important because I'll talk about some other studies that have looked at the ROX index. And if they don't get the same results, it could be due to the fact that this study only included pneumonia, hypoxemic respiratory failure. But they had very strict criteria. Again, the study was just collecting data on patients that needed high flow nasal cannula. So inclusion was the patient had to have respiratory failure caused by pneumonia. And then when they would initiate high flow nasal cannula was when they could not maintain saturation, oxygen saturation above 92 while receiving standard oxygen administered through a face mask at 10 liters per minute or more, and the patient had a respiratory rate of 25 breaths per minute or higher. They would start high flow nasal cannula at 30 liters per minute and titrate up for patient comfort, and start with an FiO2 of 100 and then reduce to maintain saturation. They had very strict criteria, and again, these patients were just being followed while being provided high flow nasal cannula or nasal high flow therapy. They had strict intubation criteria, decreased level of consciousness with a GCS score of 12, cardiac arrest, arrhythmias, and severe hemodynamic instability, or persisting or worsening respiratory condition defined of at least two of the following criteria: failure to achieve correct oxygenation. This means a PO2 less than 60 with SATs less than 90, and high flow is greater than 30 and they're on 100%. So if they meet this criteria and any of the others, which could be respiratory acidosis, a respirate above 30, or inability to clear secretions. Now, the reason why I've put respirate above 30 in bold is because this is their criteria for intubation, but it is also the denominator in the ROX index. So if your criteria to intubate is a respirate of 40, then your denominator would be different for every patient who you then decided to intubate, and therefore the score may not be as effective. So you need to understand that if this looks similar to your intubation criteria and your patient has pneumonia, this ROX index may perform the best because it is the closest to what was done in this study. I'll talk about an external validation that was done with this that did not perform as well, but there are reasons for it. So what they found is that a ROX index greater than or equal to 4.8, this was a general overall score that they chose based on a mix of sensitivity and specificity, but it's predicting success. So higher than this is success. And I have this 2x2 table, which is a typical table used to calculate sensitivity and specificity. If you're not familiar with it, I've labeled these things to make more sense. If you know, so what they did is they looked back at all the patients in this study and decided based on who failed and who didn't fail. Again, the ROX index did not decide who failed. They just went back and looked to see what number of a ROX index could distinguish between failure and non-failure. So sensitivity, this is this column here. So how many patients does it correctly identify? And then for those who are successful, but they actually would be labeled as failures, so a number less than this would be patients that are missed, and this depends on the sensitivity. So the higher the sensitivity, the less patients are missed. The lower the specificity, the more patients you have that are false positives. So they may be above this level, but they actually end up failing intubation. So as you can see, it's a relative mix of sensitivity and specificity of 2 hours. The positive predictive value is a little bit low here. And then as you go further along, 12 hours, 18 hours, 24 hours, you can see the sensitivity increases. So less patients are missed, but the specificity goes down. So you will have some patients that may actually fail, but we're above this level. So overall, this was the score, and it had good diagnostic accuracy, basically that got better as time went on. Now, what they did, and this is what I appreciate about this study, is they looked and thought, okay, well, you don't want to have a lot of people that are, this would be considered overdiagnosed or false positives. You don't want people who are going to fail or succeed and label them improperly, and if the result is to intubate them. So what they did with this score, this is, instead of being greater than, this is less than. So now it's predicting failure, different than the previous slide, which is predicting success. So notice how I have success here. Now I have failure. It's trying to predict failure. Now you'll notice the sensitivity is very low, meaning many patients are missed. That means that many patients that are above this level will likely fail. But if you're using a cutoff as a reason to intubate somebody, you do not want false positives. You don't want to intubate someone who was not going to need intubation. So what they've done with these cutoffs is they chose cutoffs with the highest specificity, so the lowest possible amount of false positives, so that you won't be intubating a patient who may not need intubation. So you see 99.2% here, 99.2% here, 98.4% here, which gives you a positive predictive value, which is 83 here, 94, and 89 when I'm rounding up. So you can see it's these thresholds, less than these numbers at these time points, highly indicate that your patient is likely going to need intubation, and you can feel confident that you're not going to be intubating someone who would be otherwise successful. Again, keeping in mind that these cutoffs were specific to patients with pneumonia, and the intubation criteria in the study was not the ROX index, it was a respirate of greater than 30 and other criteria. So just keep that in mind. But the likelihood ratios you can see are very high, the positive likelihood ratios. So it was very good at predicting failure with these cutoffs. Now, they did an external validation with the Florali trial, which is the large randomized trial comparing high flow nasal cannula or nasal high flow therapy with standard oxygen therapy and non-invasive ventilation. And as you can see, 82% of the patients had pneumonia, so not all of them, but the majority of the patients did have pneumonia, but their intubation criteria in the study included a respiratory rate greater than 40. So of course, this 40 would really change the denominator. So they did not have good sensitivity or specificity or positive predictive value or likelihood ratios across the board for using 4.88 as a cutoff. At the now they didn't have 2 hours, so they had to use 1 hour with the Florali data. At 1, 6, and 12, you can see with those cutoffs that had very high specificity in the ROX study, did not perform as well with this also. So they looked at other things that is there other elements of the ROX index that could be used? And what they found is that looking at the difference between 1 and 12 hours, so if you measure the ROX index at 1 hour post initiation of high flow nasal cannula and then 12 hours later, they found that the difference between 1 and 12 did predict success of high flow nasal cannula. So perhaps this is another way of using the ROX index. Does it increase? So this is an increase of at least 1. And this was significant. And then they looked at the ROX data to see if this difference also held true. And you can see the difference. They didn't have 1 hour, they had 2 hours. The difference between 2 and 12 actually was the stronger value here, but it was a change of 2. So in the Flurali, it was a change in 1. Here is a change in 2. So on the side of playing safe, I would probably suggest that if you have a change in 12 hours between 1 or 2 hours and 12 hours of a ROX index that is at least 2 or greater, it's probably quite predictive of success. This patient is definitely moving in the right direction. So this is a study of immunocompromised patients that looked at these cutoffs as well, and they found, again, very poor accuracy for predicting success of high flow nasal cannula. Their intubation criteria in this study was basically clinical status. It included respiratory rate, but not a specific value. So again, they did not have very strict, and I think this is the reason why the ROX index performed so well in that study, in the ROX study, is because they had very strict criteria for intubation, and it was the same as what was used to develop the score, and that respiratory rate of 30 being very specific, I think, is partially due to this. So it had poor diagnostic accuracy. However, they did find that if you separate patients with a score above 4.88 or less than or equal to 4.88, there's definitely a difference in patients who required intubation, and it's a significant difference. So it definitely was able to distinguish those that were intubated and those that were not. So why does it have poor diagnostic accuracy? Well, that can probably be shown in the first table, actually, which is when you look at the ROX index in patients who needed intubation and those who did not, you can see that, yes, the numbers are significantly different, but when you look at the range in numbers, it goes up to 7 here, whereas here, obviously, it's starting at 4.48 and going up to 8. There's a huge overlap. So when there's a lot of overlap, it makes the diagnostic accuracy of a specific value very difficult to be accurate. So using a specific cutoff of 4.88 was not ideal. So they did find that the ROX index at 6 hours per point increase was associated with a reduction in the need for intubation. So it was significantly associated with success of high flow therapy, and it outperformed many other variables that they looked at in a multivariate analysis. So again, the area under the curve was still poor. So its ability as a diagnostic accuracy in terms of with using one value to predict, it was not good, but overall it did change it. So this is actually one of the suggestions they gave, and I actually like this concept of, they talked about suggesting a concept of risk stratification, and so for quartiles of ROX. So instead of saying it's a certain number, they're definitely going to fail, let's intubate. What if you categorize patients as a level of risk? So here they separated the ROX index in quartiles, and you can see that the interquartile ranges actually don't overlap. So these boxes don't overlap each other. And so this would be someone at high risk, this would be someone at low risk. So this, if you call this risk level 1, 2, 3, and 4, again, how closely you monitor, how much you consider this patient's full-on medical picture to make decisions. If someone's in the low-risk category, then they may be better off. If they're at this level here, again, this may be more helpful rather than trying to focus on a very specific cutoff. Perhaps risk stratification would be the next step. So further data, I think, should be published with the ROX index. I think more people should use it. I think it's a very helpful tool because it does not require any blood work. It's extremely easy to use at the bedside, and more information like this is useful because these were immunocompromised patients that weren't all necessarily specifically pneumonia. Again, the intubation criteria wasn't specific for respiratory rate, so it's not surprising the ROX index didn't perform as well, but this idea of stratification is actually a good concept. It has been used in a couple of COVID-19 studies. These are research letters, so they're not full studies, but a lot of people were publishing research letters in 2020 due to the pandemic, just trying to get information out there. They found a ROX index greater than or equal to 5.37, had good diagnostic discrimination for whether or not someone would succeed on high-flow nasal cannula. Sensitivity is quite low, specificity is higher. This was after 4 hours of therapy. Another paper looked at the ROX index at 6 hours and found greater than 5.55 to be a good, to have good diagnostic accuracy. You can see the area under the curve here. By the time it gets to 6 hours, it's 0.79. 0.82 at 12 hours and 0.87 at 24. So again, good diagnostic accuracy using a threshold of 5.55 in this paper. So two different papers looking at COVID patients found something sort of in the 5 range to be something significant with it. Again, more data is needed. These were not extremely large studies. They're research articles, research letters, but definitely encouraging to see many people using this ROX index so that we can really narrow down the benefit of using this tool. This is a paper published by Tommaso Mari and colleagues, published in 2019, that I think is extremely important, that patients with a low ROX index at baseline, many of the patients which they labeled as responders, increasing flow was able to increase the ROX index. So if you have a patient with a poor ROX index at 1 hour or 2 hours, don't just say okay and then monitor it again 6 hours later or 12 hours later. See if there's room to move with flow. If you're currently at 30 or 40 liters per minute of flow, consider increasing the flow again to a maximum of 60 liters per minute and see how the patient tolerates it. And how this may affect the ROX index is most likely due to the reduction in respiratory rate that can occur when higher flows are used. So in terms of how high you can go on flow, we do know that much of the humidification is really what results in the comfort to the patient. And at 60 liters per minute, once you exceed that, you really start to exceed the comfort or the ability of the humidifier to properly condition the gas being sent to the patient. This is an example where the average flow, this is in liters per kilogram predicted body weight. The average flow here was around 100 liters per minute of flow, and you can see the comfort score just plummets there. So this was around 65. So you start to get a bit wider of a comfort zone here at 65 liters per minute, but once you get higher than 90 and 100, this is obviously very fast flow. It's probably not humidified properly, and therefore the comfort scores fall off there. I've already mentioned this paper, so I won't go into it again, but just consider that if your patient is uncomfortable or they're complaining, consider that the nasal discomfort when you're trying to increase flow to improve the ROX index, just be aware that if you're using a very large cannula in a small nair, this may be why it's uncomfortable, and perhaps you should try a different size. So the monitoring summary, the ROX index is a promising monitoring tool. Intubation criteria is likely important for generalization. So if you want to use the strict values that are provided, you may have to consider what your intubation criteria is. Further studies should consider risk stratification. I think that's a good concept. Flow settings can impact the ROX index, so consider increasing flow when the ROX is low. And comfort with higher flow rates may be related to cannula size and humidification effectiveness. And just so you know, there is a application called ROX Vector that is available in the Apple App Store or the iOS App Store and the Google Play Store as well. If it's available in your area, just search for ROX Vector and it should have the Fisher and Paykel listed there. So post-extubation, this is the last few slides here. When someone who is high risk of failing extubation, there is some data that we have related to high-flow nasal cannula compared with conventional oxygen therapy or non-invasive ventilation immediately post-extubation. The first thing I'm going to point out is that in this paper, they found that re-intubation, when you compare to standard O2, again, favors high-flow nasal cannula compared to standard O2. So if they are a high-risk patient, putting them on high-flow nasal cannula post-extubation is going to be beneficial. It's going to be better than providing standard oxygen therapy. Compared to non-invasive ventilation, you can see the diamond here crosses 1, meaning there's no difference between high-flow nasal cannula and non-invasive ventilation. So this would imply that they are similar in nature in terms of avoiding re-intubation. In terms of mortality, similar to the other systematic review of high-flow nasal cannula, there does not seem to be a mortality benefit, but the reduction in re-intubation is clear for standard O2, but not clear for here. Luckily, we have a recent randomized controlled trial looking at high-flow nasal cannula alone or high-flow nasal cannula in combination with non-invasive ventilation. So I've already mentioned that the data so far says non-invasive versus NIV. there doesn't seem to be a significant difference between the two. So extubating someone to either of those therapies would likely be beneficial. If they're high risk of failing, this can likely reduce their need for reintubation. But what about comparing high flow plus non-invasive ventilation? This paper found it significantly reduced the need for reintubation, but interestingly enough, when they looked at the data and separated it based on the level of CO2, it kind of makes sense that the patients with higher PCO2, greater than 45, this is where the greatest difference was. There was a difference here, but it did not reach significance. This is where the significant difference was in terms of requiring reintubation. So particularly, I would say extubating a high-risk patient to high flow nasal cannula is great. If they have hypercarbia, you may want to do therapy, starting with non-invasive ventilation for an hour or two, and then transitioning to high flow nasal cannula, and then using non-invasive again if the patient seems to get in a little bit of distress. Using the two in combination likely ideal. So summary of post-extubation, nasal high flow therapy appears to be as effective as non-invasive ventilation at reducing the rate of reintubation after extubation in high-risk subjects. In a recent study, the use of high flow combined with non-invasive was superior to high flow nasal cannula alone, particularly in patients with hypercarbia. So that concludes all of the practical implementations of using nasal high flow therapy that I wanted to discuss. We are going to have some time for discussion. You can follow the Center of Excellence in Mechanical Ventilation blog at coemv.ca, and you can follow the Twitter account. If you're looking for me online, you can find me on Twitter and Facebook at Resp Resource. Thank you very much.
Thank you very much. Thank you very much, Professor Brochard and Mr. Pirano, for an excellent overview on HFNO. It was very, very comprehensive. And some of the conclusions we can make from Brochard's study was there is a strong recommendation for HFNO in acute respiratory failure. And we have seen the role of HFNO in saving lives, especially during this COVID pandemic. Because HFNO, which was very sparsely used prior, has seen significant increase in its usage during COVID. And in my state, where I'm part of the government task force, the capacity building has been such that every district hospital treating with COVID has adequately equipped themselves with HFNO. And surely it seems to have saved lives in COVID, COVID respiratory failure, and it has been a very valuable tool. And the second important conclusions we could make is in post-extubation, definitely it seems to have a role, conditional recommendation. And with NIV, I think we have got a different paradigm that with NIV, it seems to have a better benefit in post-extubation. And there seems to be some conditional role in post-surgical respiratory failure. But initially, we had some enthusiasm about peri-intubation or pre-oxygenation during intubation in OT setting, but in ICU, it doesn't seem to have much of role. And another important conclusion we made was, I think in COVID-19, the study that Professor Brochard quoted, it definitely reduced the need for intubation mechanical ventilation. So that is interesting as well. And coming to Mr. Pirano, I think the ROX index seems to be of a lot of value, and it holds promise in trying to ascertain the patients who would go on to needing intubation and ventilation. Although there are some caveats with that absolute number of 4.88 as an absolute number to keep in mind. But what we realized from Mr. Pirano is in immunocompromised patients, I think it had some flaw in trying to predict the need for intubation, the number 4.88. So excellent overview on the technical aspect and the recommendation part. So some of the question I would have for Professor Brochard is with regards to COVID, Professor Brochard, what we have seen is, including the national guidelines, when patients fail on HFNO, is there a role for NIV? Or would you believe that a combination of HFNO with NIV in patients who have worsening respiratory failure may have a role, although there are not many studies? Or would you believe when someone fails in HFNO, they should be intubated? So, question to you, Professor Brochard.
Okay, thank you. I don't think there is a simple answer. And the reason is you may have COVID on top of a chronic condition like COPD or like obesity, hypoventilation syndrome. And we have seen a lot of obese patients. And in these patients, yes, it would make sense to try using a technique which is has been demonstrated to be efficient for COPD exacerbation or obesity hypoventilation, which is NIV. And so in these patients, yes, I would suggest to use it. In young patients who is young or who no chronic conditions related to the respiratory system, who is able to hyperventilate, with a low CO2, I would say I don't think we have any evidence today. It may be risky delaying intubation. If you think the patient needs intubation because struggling with high work of breathing, dyspnea, and severe hypoxemia, the data today do not suggest it's a good way to do it. So think about your patients. What is the underlying conditions? And we have seen a lot of obese patients who may benefit from breathing spontaneously with relatively high PEEP and a little bit of pressure support, so with NIV. So yes, that may be helpful. But in other situations, the benefit of high flow is to reduce the need for minute ventilation. So you need less minute ventilation, so that helps the work of breathing. You don't have that with NIV. You add external support. So if the patient does not have the need for this decreased ventilation, it going to face mask NIV, a patient failing high flow, this is risky. I understand that there may be situations where it's impossible to do differently because there is such a surge and you have patients everywhere. But yeah, I would think precisely who is my patient I'm looking at, and what are the general indications in this type of patients.
Thank you, Professor Brashard. And what we have seen in our COVID experience is it is much easier using HFNO vis-a-vis an NIV in a COVID situation where the expertise of a nurse looking after such patients is very less with HFNO as compared to NIV, Professor Brashard. And another question I had was in many patients, many young patients, they look remarkably okay, but there may be tachypnea more than 30, where they may be generating a huge minute ventilation. So these patients, would there be a concern of SILI, self-induced lung injury in these patients who are breathing at a higher respiratory rate with a huge minute ventilation and with HFNO? Because we have understood the pathophysiology is a little different. At some early stages, these patients have a higher compliance. So would you believe the SILI is a risk that we need to factor in when we're using HFNO and delay intubation in these patients, Professor Brashard?
Well, that's a very good question and a very difficult one because so the notion of self-inflicted lung injury is related to high respiratory drive leading to high respiratory effort, which may create some negative pressure pulmonary edema, which may worsen the strain of the lung, etc. And the problem is that we do not measure drive, we do not measure effort. We measure rate, which is a poor surrogate for effort. And the only thing we can do is look at the patient's breathing pattern and the use of accessory muscle, and it's really the clinical examination. So you need some skills and expertise there to say, we have been discussing a lot this patient with silent hypoxemia or happy And I think it's related to the fact that with the COVID and the SARS COVID virus, there is neo formation of new vessels in the lung, which create shunt. So the mechanism of hypoxemia is not the same than in a typical classical bacterial pneumonia, where you have a very strong association between the amount of lung injury, atelectasis, hypoxemia, and dyspnea or work of breathing and compliance. There are patients where it's dissociated. So in these patients who do not look too bad in terms of clinical impression, work of breathing, I would not go for an early intubation, okay? But
Yeah.
that being said, yes, we have seen patients who have been struggling for days and days and days and who look terrible after intubation. And you may think, yes, maybe they have been intubated too late. So it's difficult because there is no biomarker to say this one is at risk, this one is not at risk. There is even no objective measurements before intubation. So it's really the clinical examination, which say this patient is working very hard, and also maybe asking the patients how the patient feels. You know, it has been remarkable to see this patient very, very hypoxemic, but still talking on the phone, on WhatsApp or whatever. So perfectly maintaining well. You don't want to intubate too early these patients. So that's only those who really are struggling well. And we have seen a pattern compatible with the risk of self-inflicted lung injury, especially in the recovery phase. You know, after intubation, patient put on sedation, then you start to have the patient waking up, and then you see them breathing like crazy. So I think this is where the risk is the highest. I don't know, Tom, if you want to.
Thank you.
Yeah.
No, I agree.
Thank
I
you,
think the only
Roshar,
thing I
for
would
that.
add is, that if you are to use non-invasive ventilation as a possible strategy to avoid intubation, that you do so understanding that within a very short period of time, you should be able to clearly understand if there is benefit to the patient. So if PF ratio has not improved, if respiratory rate is not improved, there's a score called the HACOR index, which was on one of my slides, but I didn't discuss it, which combines hypoxemia, acidosis, consciousness, oxygenate, like respiratory rate, a number of variables to determine, is this patient at high risk of failing? But all of this information, you should know within 1 hour if your patient is if NIV was the right solution for them. Not 6 hours from now, 8 hours from now. You don't continue on for 8 hours with a patient who has simply stabilized. What you want to see is an improvement. You don't want to see them just staying bad. Yeah. You want to see them obviously improving. And I think that should really dictate within a very short period of time to make the next step towards intubation.
Yeah, Pirano, that's well said. What we often see in the practice is, as Professor Brochard said, these patients look reasonably comfortable, meditating well, talking on the phone. But somewhere there is a little sort of a nudge for us to use NIV because it reduces the work of breathing. And if you see NIV, that seems to be a distinct sort of an advantage with NIV, where your work of breathing could be little reduced. And that doesn't figure out in the advantage with HFNO. So would you believe that to reduce the work of breathing, an intermittent strategy of using a bit of NIV would help? Because we often tend to see that the work of breathing tends to be a wee bit better when we are using NIV along with HFNO, although this strategy has not been published in any literature. So your thoughts on that, Pirano?
I think similar to what I just said in terms of if you were to try it, if it does reduce work of breathing, you should also look for other factors that are improving, like specifically if it's a hypoxemic patient, because the severity of their PF ratio, for example, as Dr. Bouchard nicely showed in the data from LungSafe, that the more severe the PF ratio was for patients with ARDS, assuming that's what they're developing with COVID-19 pneumonia, the risk is nearly 50%. So the question is, how do you identify the risk? Despite looking at just work of breathing, you have to assume that the PF ratio has improved, and PF ratios less than 150 already have been shown to have a predictive value for failure. Depending on your non-invasive device, if you're using a non-invasive ventilator that has a dual limb circuit and you can monitor expiratory volume, a tidal volume greater than 9 mils per kilogram of predicted body weight is another predictive element of failure. So although they may look like they're working less, they're still taking in large volume. So elements like that can really help to determine, because what you don't want is to be fooled that, oh, I think they look a little bit better, but clinically they're not actually improving. Those are the patients you're likely you're assuming that they're improving, but you really do need the data to support that. Okay, this is clearly someone who all of the risk factors are now improving, and they're no longer risk factors.
Yeah.
Whereas if the risk factors are still there 1 hour, 2 hour after initiating non-invasive ventilation, then you really do need to consider that. How long can I keep this patient like this, knowing that they meet all this risk factor criteria and knowing that failing NIV is actually associated with worse outcomes? Do you wait until they fail or do you implement early? And there's been many studies looking at early intubation versus late intubation, and they're actually all over the board. Some show there's no difference early versus late. Some show it's better to intubate early, and some show that it's better to intubate late. You have to really look at what they classify as early versus late. So there is some confusion in the literature. Some people would make a cutoff of 1.5 days. Anyone after 1.5 days was labeled as late, and 1.5 days early was considered early. So it's hard to determine early versus late. You just really have to consider, are the risk factors going away or are they still present within 1 hour of NIV? Then I would definitely move on to intubation if it's not.
Yeah, great insights.
I agree with Tom. I think people should think that we do not measure work of breathing, right? So we say, we want to decrease work, but we don't measure it. And the respiratory rate, we mostly look at the respiratory rate, is not very good, especially when you apply pressure support, because pressure support may artificially decrease the rate without decreasing the work of breathing. So you have to be very careful. I would say, okay, if the patient say, yeah, thumbs up, I feel better, that's good. That's probably good, but that's not so frequent, right? So be very careful. Remember, the high flow also decrease the work of breathing because it decreases the need for ventilation. So it's not a big decrease, but it's significant. So you have to be sure that with NIV you do more than that, and it needs very careful adjustment. It needs a good patient. So just be careful.
Yeah. If people review the slides, they'll see the risk factors I have for non-invasive ventilation. Respiratory rate's not one of them. So it's really not a good predictor of failure, just as Dr. Burchard mentioned. So, and work of breathing is not on there either because, as he mentioned, we're not inserting esophageal balloons as standard of practice for patients on non-invasive ventilation. So we're not objectifying work of breathing for sure.
Yeah, I agree. I think work of breathing is very subjective and it is fairly variable. Another question is one of the distinct advantages that is claimed out of HFNO is it produces a bit of a CPAP effect. But this is arguable, isn't it? Because many of the patients are mouth breathers, and it is very clearly shown when someone is breathing through the mouth, you lose this CPAP effect. And I believe 60% of our patients are mouth breather, or maybe more than that. So would you believe that this is sort of a hype, that CPAP effect, and it's a very minimal CPAP effect of 3 to 5. Would we really believe this is something very relevant, or it is irrelevant in this whole setting? Both of you can comment on this.
That's a very interesting question because you, as you mentioned, when you open the mouth, you lose a lot of the positive pressure effect. I think when the mouth is closed, you're around 5 to 7 centimeters of water. So if it depends a little bit on the cannula you use and the size of so you be careful with that. But it can provide a significant PEEP effect, not a large one. And indirect data looking at the change in lung volume also suggests you have some effect. So I don't know why patients choose to open their mouth or keep their mouth closed when they're on high flow. I don't know if it's a physiological response, but I think we did recently a study which is not yet published, but where we measured the resistance to breathing, and with high flow continuous in the nose and nasopharynx, in a way you increase the expiratory resistance to breathing, which if you close the mouth will result in positive pressure. If you don't close the mouth, will go down to zero, but it may help to maintain the lung more open during expiration, which for acute lung injury may be interesting. That may be also interesting for COPD, like a kind of pursed lip breathing, maybe with lower flow, so we don't know. So I think it's a very interesting aspect, which we don't understand completely. So I have to say I am surprised, because I see that the positive pressure is not there when the mouth is open, but clinically we still see these benefits despite the fact that many patients have their mouths open. So is it more an expiratory phase effect, maintaining the lung open more for longer? It's possible. We need to explore that.
Thank you, Professor Boscher. There are a few questions from the audience. We'll quickly go through them, and possibly it will be time for closing the session. So there have been two questions where they've again asked, how does HFNO reduce the physiological dead space? And would this be related to the anatomical aberrations that would exist in the nasal cavity as well? So comments from any of both of you.
So the way you should think about dead space, it's wasted ventilation, if you want, or inefficient ventilation. So if you start breathing, you will start to inspire what is in the upper airway, the oropharynx and the oral and nasal cavity. And what is there is not fresh gas, it's the rest of the gas you expired, which is full of CO2. So you start by inspiring that. The high flow is there to continuously wash out this during expiration. So when you start inspiring, you avoid this wasted ventilation. You go directly, you start directly by inspiring the fresh gas with the titrated FiO2. So this is how it works, which is a really interesting mechanism. During mechanical ventilation, a lot of people have tried to achieve that with what was called continuous flow insufflation, where you put a catheter down the trachea to wash out the dead space. It's exactly the same principle, but it was more complicated because a catheter in the trachea can move, can be obstructed, can increase resistance. So it's a very simple and interesting physiological effect, which explain the decrease in the work of breathing. I think, I'm not sure, I think the decrease in respiratory rate is more related to the increased resistance to breathing, but it may also participate.
Yeah, I generally describe. I generally describe the nasopharyngeal dead space. The easiest way to understand it is that anatomical dead space is just rebreathing dead space. It's just rebreathing volume. So everything that you inspire, you're just rebreathing something you exhaled already. So the simplest way is not to get too complicated with the word dead space. You're just rebreathing exhaled gas that never left your face. That's the simplest way to understand it. So by constantly increasing the flow, you're just washing this out. Yeah,
great. I think that's a question for you. How to wean from HFNO Is there any set protocols, or is it just cranking down the flow rates as one would have increased with the need? Or is there some algorithm or some scoring tool, Mr. Pirano?
Essentially, the way that I look at it is consider your reasons for starting it, and then you're working backwards. So let's say your reason for starting it is because they require 50% FiO2 and a respiratory rate of 25. So if you have strict criteria for when you would initiate it, the question is, okay, I'm going to reduce my FiO2 first. So once I settle them, I've increased the flow. I'm going to increase my FiO2 first. Once they are below the FiO2 criteria for starting it, I know that, okay, FiO2 is weaned. Now you have to consider the flow. As we've mentioned many times, the flow likely has the biggest impact on respiratory rate. So as you reduce your flow, once you get to something that is below what you would initiate at, so if you initiate at 40 or 50, I would say go to 40, try 30. Once your FiO2 is less than 50, let's say, so FiO2 of 40 and your flow is at 30, try something, you can try removing it at that point, provided the respiratory rate has not increased when you've decreased your flow below 40. That would be the most logical reason. Just consider your reasons for starting it, and then just make sure you've gotten back to below that threshold criteria of respiratory rate and FiO2.
Yeah, thank you.
But typically
you.
FiO2 first, followed by flow afterwards.
Yes. So there are two sort of problems we found when we increased our usage of HFNO, especially during COVID. One of the thing is there is a extensive usage of oxygen, and in the peak of our COVID, we had issues in maintaining the demand supply of our oxygen because it consumes a whole lot of oxygen. So it can be resource crunch for in a situation when things really peak up and when you have a short supply of oxygen, at least the supply chain gets interrupted. So we had this serious issue because of the increased usage of oxygen. So that is something. And the second important aspect that was always we had some issue is titrating the FiO2 and the flow rates, Pirano. So because many a times these flow meters not necessarily are validated to accurately indicate to us what is the FiO2 in relation to the flow rates that has been set. So is there any way that these two things could be sort of optimized better, Mr. Pirano and Professor Brochard as well, any of you?
I know that depending on the device, it can become challenging for knowing exactly how much FiO2 you have. I do know that there are lookup tables that you can find online for, total flow and the amount of O2 that's being teed in and what the percent oxygen may be. That may help you to determine how you set these devices, assuming you have a different flow meter for air and one for oxygen. So if you're feeding them two of them in, another way is to use a blender. The blender should only entrain enough FiO2 that is required within the flow rate, assuming that the blender is optimized. The Airvo devices, if you have the actual Fisher and Paykel Airvo device, again, you're just teeing in so you can at least closely monitor how much O2 there is come in. Having said that, I have personally also noticed a persistent need for higher levels of FiO2 in many COVID patients, even in the post, like in the weaning phase, even on the ventilator, where they're needing 50% FiO2 longer than what most would expect, despite weaning and moving forward. It seems they still respond to FiO2. They have an increased drive when you try to reduce it. They start working, and so it definitely is a challenge. I don't know any tips in terms of preserving FiO2. I think just understanding how much you're delivering, and really you're going by oxygen response. So whether it's 40 or 45% when you're titrating it, it's really just keeping your saturation in an acceptable range, which can sometimes be challenging. And some patients may need a higher saturation just to reduce their drive. And this can be challenging when resources are low. Maybe Dr. Bouchard has some more comments too.
No, that's a good point, and I like to call it high flow nasal cannula, not high flow nasal oxygen. The reason is that this is not only a tool for oxygenation, right? This is why we describe this washing out of the dead space, which has nothing to do with oxygenation. It's a CO2 washout. It's a benefit on ventilation. I'm saying that because you should dissociate in your mind. And again, of course, often it goes together, but the ventilation part, the patient struggling, the work of breathing, and the oxygenation part. So, for instance, maybe what Tom described is patient, you decrease FiO2 is struggling more, so there is nothing you can do about it. You need to maintain the FiO2. But you may also have a patient who tolerates very well lower FiO2, lower saturation, and will still benefit from the high flow, which will not be a very high concentration of oxygen. So I would say this would be my only recommendation. Try to dissociate the benefit of the flow from the benefit of oxygen concentration. Sometime, not always, but sometime, you can keep the saturation relatively low in the 88, 90, but high flow to decrease the work of breathing.
Yeah, I think that's a very valuable comment, Professor Brochard. So I think we're coming to the end of it. So that's the last question and the last sort of an observation. Professor Brochard, we are increasingly seeing, as you would agree, that patients with COVID tend to develop fibrosis. And many a times they're occupying a valuable bed in intensive care, and they're not, they cannot be moved out of the valuable ICU bed space. Sometimes we put these patients to the ward with HFNO, and eventually they need to go home. So we have difficulty in providing this HFNO if the need is such that they will continue to need HFNO and they have developed advanced fibrosis. As a tool at home or at a recovery center. So what are your comments on this? Are there increasing number of cases which eventually would remain at home, possibly needing HFNO or high concentrations of oxygen? And there is technical difficulty, which I'm sure Pirano would have comments on that, because of the flow meter and the increased amount of oxygen that one would be needing. So your thoughts on this, Professor Brochard and Pirano?
That's again interesting point. I don't think we have so many data about that. We have only few studies looking at the pulmonary function and general function of patients who had COVID, and it seems that at 3 months you still have a lot of patients who have at least patients who came from the ICU and have been under mechanical ventilation. You still have some restrictive patterns, sorry, and of course DLCO is always a bit low, and maybe later on they tend to recover, but we don't know very well, and we don't know. We call it fibrosis. We are not sure. We think steroids have been helpful. Again, I just would recommend that we need to dissociate the potential benefit of high flow because of the flow from the benefit of oxygen. And if you think about that, it makes things easier to send back someone at home with high flow with a low concentration of oxygen, because they rarely continue to be very hypoxemic. But that's just a general comment. I don't think we know enough, but again, dissociate the effect of the flow from the effect of oxygen, because of course, if you need high oxygen concentration, it becomes impossible at home. But
yeah, I have no more to add.
Comments?
That's exactly what I would say. Yeah, I agree.
Yeah. So thank you. So thank you very much, Professor Brochard and Pirano, for excellent insights into the whole concept of HFNO, and I value the comments dissociating flow and oxygen. I think that becomes very important when we come to optimizing the resources. So I think that's a very useful point that we could drive home, that we need to dissociate flow and oxygen and try to optimize your oxygen requirement, because that has been an issue, at least in our state, where oxygen consumption was going up, and we continuously train our nurses to make sure there is no wastage of oxygen by keeping very high oxygen concentrations, because not many, as Professor said, many of them improve eventually and they don't need very high oxygen. And we all have understood hyperoxia also is dangerous, isn't it, Professor Brochard? So too much oxygen also is not good. And many studies are even looking into how much oxygen is good enough. So thank you very much, gentlemen. So it was a great time. So we learned a lot, and I'm sure the audience here are a lot more enriched, and they can care for their patients better with all the knowledge gained from you both. So thank you, Mr. Pirano, for taking time out of your busy schedule. Thank you very much, Professor Brochard. I know you are an extremely busy man. So it was indeed our delight and pleasure to have you both. So I hand over to Fisher and Paykel to do the concluding remarks and close the session. Over to you.
Thank you. Thank you very much.
Thank you.
This is Rajesh from Fisher and Paykel. Thank you, Professor Brochard. Thank you, Mr. Pirano. And thank you, Dr. Pradeep, for this very informative and interesting session. And last but not the least, we'd like to thank ACME for putting this event together and making it successful. Thank you, everyone.
Thank you all. Thank you. Have a great day. Thank you.
Bye-bye. Thank you.
Thank you. Bye.